Hello, welcome to second topic in series of improving CMR image quality. Here we will deal with abnormal heart rhythm. So patients with abnormal rhythm are often referred for cardiac MR and the image quality is really compromised. It is important to learn about some few techniques, at least so that we can get reportable images. It is important to understand that ECG obtained during MRI is always distorted, more so in 3 Tesla images. It can have elevated T waves or some amount of ST segment elevation or depression. This ECG is not to be used for diagnostic purposes, and this happens because of the magnetic field effect on descending aorta flow. It is also called as magnetohydrodynamic effect. Adequate ECG is essential for a good quality CMR. So if you do not have a good ECG, you can try shaving of the chest hair, cleaning of the skin. This abrasive prep gel, the skin gel, more than ultrasound gel, I have found this gel which is very effective. Changing the electrodes, and best is to keep them over the bony parts near to each other. We can change the polarity of the leads and just get good quality ECG getting signal with good R waves. In case if you do not get adequate signal, it could be either because of skin contact, then you can change the leads and use the adhesive gel. If the lead cable is loose, you can check the lead cable, and in case if still you do not get it, you can try putting it even on the back. If the ECG waves are low amplitude, you can either move the leads close to each other or just toggle the lead polarity. After getting good quality ECG you can identify the arrhythmias, and depending on whether they are variable isolated ectopics, then we can use arrhythmia rejection. But however, there are very variable arrhythmia, especially like bigeminy, trigeminy, you can also try prospective triggering. And in cases like atrial fibrillation with highly variable arrhythmia and multiple ectopics, real-time imaging is the last resort. In using arrhythmia rejection, it is important to understand the trigger window. So as in this case, whenever you see the ectopic, use the trigger window so that this entire ectopic will not be taken into the account. So for example, here the data will be accepted between 800 to 1200. So neither this beat will not be taken into consideration, it will be rejected. The time of acquisition will increase, but at least the image quality would be optimal. Prospective triggering is you can choose the trigger and choose the leads or choose the beats only which are good and adequate quality. However, in prospective triggering, it is not obtained during complete cardiac cycle, and hence functional evaluation will not be possible. Normally we use the retrospective triggering, where the acquisition window is throughout the cardiac cycle, but here in prospective triggering, some part of the cardiac cycle may be missed. Last resort is real-time imaging, where we can assess the ventricular function without any breath hold. The entire stack with prospective gating can be obtained. It is ideally gradient echo single shot SSFP images, but unfortunately functional evaluation is not possible, and the spatial and temporal resolution is also very less. Similar articles can be seen in our book, and for any feedback and suggestions, please mail us on info@mricardiac.com, and this is my personal email address, priyachutgar@gmail.com. Please share your feedback. Thank you.